I'm Jeff Borkin. I'm the Chair of Family Medicine and the Assistant Dean for the Primary Care Population Medicine Program. We have a great afternoon for you. So I think as you've seen, we really want to heat up the conflicts, the controversies. But Alan is not going to let you go home. You can't leave Rhode Island until we have solutions. So he's canceled all your tickets, whether it's on Amtrak or it's by plane, even your cars, your alternators are gone. So we have 4 excellent presenters, and I think as Alan mentioned earlier, there was a multiplicity of great proposals, and we're sorry we couldn't hear them all. But we're going to have hopefully something for everyone. We're going to talk about assessment. We're going to talk about will there be polling. We'll even have video games tossed in. So without further ado, I'm going to introduce Senthil Kumar Rashekaran. Will be followed by Karen Hauer, Julie Story Byerly, and Richard Van Eck. They're going to have 12 minutes exactly to present. There'll be room for 1 to 2 clarifying questions as they finish in 12 minutes. Following, they will be sitting up there and we'll have a panel to begin to get into the discussion. And I believe that you would like to call someone else to help with polling.
Yeah.
So, I don't know how many folks have used Poll Everywhere. There should be instructions on your table. Most people in the room have probably experienced it at some point. You can either join via text, messaging and data resupply, just to say that. But if you text CFC 2018 to 37607, it will send you a link if you just join. We'll make it more efficient during the course of the presentation so you can just answer the questions. Or you can do it via your web browser at pollev.com/CFC 2018. Go that route through your web browser. The first question will pop up because it's activated in the presentation. Please don't answer. Close your eyes and ignore that it's there. Any questions about that?
Thank you, Lauren. She was the brain power behind this creative technology use. Thank you. Over the last Easter weekend, one of my best friends' family came over. And are you all able to hear me? Oh, awesome, thank you. And he has 2 children. One of them is in elementary school. And he said his son was doing a math homework. And when he saw his parents were not around, he said, "Alexa, what's 14 times 16? So Alexa said 224. And so new generations require new types of assessments. My mother, in addition to being the sweetest person on the planet, was a nurse working in this small-town hospital in the southern India. And she was a tremendous inspiration for me to pursue medicine as a career. That incessant obsession with medicine took me all the way to Russia to pursue my undergraduate medical education. And from there, I came back to India to pursue my graduate medical education training. From there, I was really blessed with an opportunity to travel to Europe to work there at National University of Ireland in Galway for a couple of years. And life took me to the Caribbean, where I had the first opportunity to have an immersive experience in American medical education setting. And what surprised me was the entrustment decisions that are being placed on students based upon their performance on the multiple choice questions. That was really surprising to me. And having been in all these countries and almost continents, I can say for sure that we're killing our students with assessments, literally killing them. So what does the world at large talk about the way we assess doctors? Here is a Forbes article that talks about are actually advocating for stopping to wasting doctors' time and resources by over-testing them. Here is a Washington Post article that's talking about a disturbing truth. I'm sure you'd all know, many of you would have read this. The disturbing truth here is the surprise from the wider community that we use multiple choice, text-based questions with 5 options to place entrustment decisions and residency placement decisions. We as a profession take pride in calling ourselves as people who practice evidence-based, right? Let's see what the evidence says. I think Catherine, this morning you made our job easy by showing all this evidence. So I'm going to skip through these slides much more easier than I thought I would. But even though this talks about the USMLE, it's not about just USMLE. It's about use of multiple choice questions in our own test settings. So I'll read this for you. The conclusion of this finding, this study was there's a low correlation between USMLE performance on a OSCE exam that suggests two things. Either the written exam is a poor predictor of actual clinical performance, or the two methods actually evaluate different skill sets entirely. And this is a widely referenced study that many of you, and this morning also was quoted, that there is no validity argument about using step 1 and step 2 scores for PG residency selection decisions. And this argument is neither structured, coherent, or evidence-based. Okay, so again, it's just not USMLE. It's also the multiple choice questions that we use in our in-house exams as well. So as a result, we are saying it's not good and not evidence-based, yet we are doing it. So what our students are doing is just, this is their curriculum, pretty much. We might have all the cool curriculum that we can think of, but this is their curriculum. Look at the first aid, it's tattered and torn. I guess it's for a reason. And they're literally sleeping with the books. This is the first aid. So patients don't present with buzzwords, right? And they don't have pathognomonic signs. Yet all the multiple choice questions are written with buzzwords. Even if you don't write them with buzzwords, within 10 iterations, the students figure out buzzwords. Patients present with rich emotions, facial expressions that you should see through and see into sometimes. They carry rich body language that speak volumes of what they are going through. They have their own signs to convey their experience of illness, which is different from a patient to patient. They have their own choice of words, certainly not buzzwords. And most importantly, they don't know what is important or pertinent. Everything they say is based upon what you ask. So what I'm going to offer you is not the solution, but at least hopefully a solution to this problem. And instead of me explaining the solution, in brainstorming this with Lauren, she has suggested that we have you really experience this through the poll everywhere. And this is based upon how many of you here are familiar with the Myers model of multimedia learning? Great, thank you. A few of you are, great, thank you. So primarily this is based upon that model where our human brains process texts, videos, pictures, and audio totally differently, okay? So I'm going to play a video. Please listen to it carefully, and then you have to answer the questions using the poll. And you're not being graded, and none of it is recorded here. Oops, sorry.
Okay, well, I see that with the new meds that your blood pressure looks better controlled today. It was really high when I saw you a month ago.
Yes, I'm pleased with that reading, and I'm happy that it went down, but I have this bothersome cough.
Tell me more about that.
Well, it's a coughing spell that I have. It's dry, nothing comes up. It seems to get worse. It seems to just keep getting worse no matter what I take. I've tried cough syrups, cough drops, and nothing seems to help. So I just really need you to help me figure out what's going on. Sometimes it's so bad that I feel like I'm going to pass out.
Oh.
Yeah, so you think I need antibiotics?
Well, we'll look into that. I'm sorry you've been feeling this way. Have you noticed any fever?
No.
Any wheezing?
No.
Any difficulty breathing?
No.
Okay. Have you had any sinus drainage?
No.
Anybody at home sick?
No.
Well, why don't we take a look at the medicines you brought, and then we'll do a physical exam.
Okay.
Okay, so hopefully you got a sense. I just took a very high, super high yield USMLE step 1 question, ACE inhibitor induced cough, right? And so I'm glad that all of you got it right. It's great. But the deeper message is you can use this one simple vignette of any kind. You could create that, and I'll talk about how to create this best practices in a minute. You can test anatomy. For example, in this case, you could have tested what is the cough center in the brain, for example, right? Or you could have had a basic pharmacology question. What's the mechanism of action of ACE inhibitors, for example? You could have had a question about cost-conscious care, a reflection piece, evidence-based medicine, talking about the African Americans being more prone for adverse drug reactions with ACE inhibitors, for example, right? The list can go on and on. Here is the next video, which has more richness to it in terms of what you can do with it. And there is no multiple choice question associated with it.
I hit my head on the counter, and I'm still having this headache.
All right, so you hit your head on the counter, you have a headache. Did you have any other concerns you wanted to address today?
I've got a few things going on at home, but my husband's going to be wondering where I am, so if we could just talk about the headache.
Okay, sure. Tell me what's been going on from the time it started until now.
It's my fault. I think there were some boxes on the floor, and my husband always tells me I'm just clumsy, and it's just a stupid accident. I just think I tripped over something.
Okay. Now you watched it. I just want you to reflect on this question. What scenario is depicted in this video vignette? And if you're using two words like communication skills, please use an underscore between them, because if you type in two separate words, it'll show us two words. Awesome. So what you're seeing here is pretty much every single person has typed in intimate partner violence in some one way, shape, or form. So what I'm trying to say through this is it's valid and it's authentic, meaning you can depict, if you're careful enough in designing these videos and having this script properly managed with the standardized patients, you can have a reliable way of depicting this clinical scenario, which is more likely how our students are going to interact with patients, right? And you can stop. That video was only 40 seconds long, which is much shorter than how long it takes for you to interact with a multiple choice question, whereas it's much more richer and more realistic. I want to get your thoughts on the health system using the concept being using a short video vignette of minute long or 40 seconds long. What are all the concepts that come to your mind from health system science that's near and dear to all of us here? What are all the concepts that can be tested if you can just type in? I would love to hear your thoughts. You could submit multiple answers for this one too. Okay, as you can see, what you're seeing is you can test lots of concepts within the health system sciences using this approach. And also you can use this stimulus, a video stimulus, which is authentic enough to use that as a short answer, long answers, guided reflections, and matching a true-false. And also you can test multiple concepts that you just shared in the slide before. So in terms of feedback, what did we receive from experts? I'm not sure how many of you heard about Richard Meyer, who is the godfather of the multimedia learning theory. One of the most gratifying moments of this project was an opportunity to have two one-hour-long conversations with this world-renowned expert. And he had nothing other than positive feedback and words of encouragement for us to continue this work. And his suggestion is that everything what he proposes in learning will also translate to assessments. And we also had a chance to partner with Dr. Anne Kring, who is an internationally renowned facial emotions recognition expert. She was the one who came up with the facial expression coding system, who said every standardized patient encounter can be facially coded for appropriateness, meaning it can be authentic, it can be reliable as a source of assessment tool. My hope is that we'll be able to transition from our students from our left to the right where we can get it right, okay? And I'm super thrilled that the AMA is launching the new innovation grants. And if anyone of you are interested in partnering with us in creating these scenarios, we have state-of-the-art standardized patient facility where we can do this. And so I would love to hear from you all. Thank you. And I'll leave you with this quote.
Thank you. Time for one clarifying question. You have a clarifying comment you want to make?
Without a question, no.
Okay.
All right. Hi, everyone. My talk is entitled Clerkship Grading, the Illusion of Objectivity. I'd like to start by sharing two stories with you. The first story is about a student who asked to meet with me early in his 4th year of medical school. He had just finished all of his core clerkships and received straight pass grades, not a single honors, and he wanted to think through what this meant for his future. So we looked through his evaluations and we saw that he had received scores that were all clearly in the passing range or above, no red flags as we say. And his comments all praised his reliable data gathering, his collaboration and team spirit, and his hard work. So I asked him what feedback he'd received about what he needed to work on, and he said that people seemed to think that his oral presentations could be better, but he was unsure what they really meant by that or what he was supposed to change. The second story is about an email that I received from one of our clerkship directors. The clerkship director forwarded a message that a student had sent to a preceptor in this department. And the student's message had said, "Dear Dr. Preceptor, thank you for being a great teacher. And I want to remind you to fill out your evaluation about me. And if you happen to give me all 4s, which is our highest score, that would make me eligible for honors." We have a lot of grade inflation at our school. So I couldn't help but wonder as I read this, was this a student talking to a teacher or was this a request for a Yelp review? But really, these stories together made me think, what are we communicating to our students about what we value and what's important in becoming a good doctor that's leading them to ask these questions and behave this way? Our clerkship grading system really creates high stress for our students, much as we've heard in the earlier discussions in this meeting about Step 1 scores. We take the complexity of clinical performance throughout a 4 or 8 week rotation and reduce it to an A or an honors or a pass, which really falls short of communicating what we want to know about our students. Students feel highly stressed about their clerkship grades, and I will argue in this talk that clerkship grading, as we now do it, is interfering with our students' learning. It's creating inequitable learning environments, and it really lacks the precision that we think that it's communicating. Clerkship grading typically entails a student rotating on a service for a number of weeks, working with many different team members, residents and faculty, who then fill out an evaluation after working with that student for some period of time. At the end of the rotation, the clerkship director or perhaps a committee puts together that information along with an exam score and maybe a standardized patient or other assessment, and then perhaps normatively or perhaps trying to use some criteria determines whether this was an honors or a high pass or a pass performance. We should be aspiring to a different kind of system, a system that uses assessment as a tool for learning rather than focusing on assessment of learning. If we think of that more ideal state using these 3 learners here, we'd see that the learner on the left was coming to work or to school saying, how can I get to the next rung on the ladder? What do I need to do today to be better at taking care of patients, at working with this team than I was yesterday? The student on the right would similarly be thinking, how can I continue to improve? Instead of thinking, how can I catch up to this person in red who's going to beat me to get that coveted honors? Another benefit of assessment for learning is that even this student in the middle who seems to be excelling would still be aspiring to that next rung on the ladder, recognizing that improvement is something that occurs throughout one's career, not just when you get the grade that you were hoping to get. We currently have a problem, as we've been talking about throughout this meeting, that assessment is driving learning in ways that we don't want it to drive learning. Our students are very clear on what they need to do to try to earn honors, and as a consequence, their learning is often skewed in their clinical rotations in ways that none of us would say are optimal for learning to be a good doctor. A student who spends time with patients may realize, gee, my team didn't actually see me with the patient, so I should have been studying for the test because that might have been higher yield for my learning. A student who spends time planning a complex discharge with the social worker and with the nurse will be frustrated when they figure out that those people aren't going to fill out an evaluation at the end of the month. And we sometimes hear from students at our place that they don't even feel like they should ask a question unless they already knew the answer. And if they already knew the answer, they might ask that question because maybe somehow they can work in that they kind of did know that information, and then they'll look smart. So really, those are not the kinds of learning behaviors that we would hope to see for our students. But it's hard to argue that they aren't strategic in a competitive environment where you're trying to earn a limited number of honors. I mentioned at the beginning of the talk that clerkship grading suffers from what I call the illusion of objectivity. Many of us were math and science majors. We grew up in the psychometric era. We feel like if we can measure it, if we can put a number on it, then it must be objective. And if we can't put a number on it, it must be subjective. But clerkship grading really is quite imprecise in the way that we commonly conduct it. When you think about residents and attendings filling out evaluations about their students, they work with the student for what used to be a month and then 2 weeks, now 1 week. Our local favorite is our service that has hospitalist of the day, who still fills out the whole giant form about the student, and then receives the form not right after they work with the student, but maybe a week or two later, and then puts it off for another couple of weeks. And then in my job, I get the email from them saying they can't remember the student, even though we put the picture on the form. And so we have to help them try to remember which student that was. And then they fill out the form so that they don't get dinged for not filling out their evaluations. So that's a problem. We also know that evaluators don't watch their students doing the skills that they are rating. They rate history taking and physical exam, even though students say they go through whole clerkships, whole core clerkship years without being evaluated at the bedside performing those skills. So those evaluators are rating those skills based on a nice oral presentation or a nice note or maybe just a nice student. The narrative comments are similarly flawed when we think about how they're often put together about our students by their frontline teachers. We understand that teachers want to be nice and teachers don't want to cause any problems or harm their own teaching evaluations. So those evaluations may contain coded words that we've kind of learned to understand, but our students definitely don't. You know, we know that good means bad and strong means really bad, and improving or developing mean average or mediocre, but definitely not honors material. So it's really no wonder that that student I met with that I mentioned at the beginning of this talk couldn't understand his constructive feedback because it was actually pretty unclear. Our current evaluation and grading systems are flawed in the way that all students experience them, but some students suffer those consequences even more than others. When we have students who are familiar with our environment, for instance, the students who are children of doctors, the students who worked in the healthcare system before they came to medical school, they start a clerkship and then their evaluations say they hit the ground running. Their very first evaluations look good. And in our school, at least, those first evaluations really need to look good or else they are out of the running for honors. The student who maybe came from a different background with less advantage, or a student who comes from a different race or ethnicity than the majority of providers in our healthcare environments, might take longer to get up to speed. So you could argue they actually learned better because they learned more over the same period of time. But they will be out of the running for honors. And then, as you've heard earlier today, with the cascade effect of that pass grade that they will receive, they may be out of the running for AOA, they may be out of the running for a competitive specialty or a competitive residency, all because of that first couple of weeks or that first couple of clerkships at the very beginning of medical school. These problems are exacerbated by the innovations that many of us are engaging in that now have our core clerkships starting halfway through second year of medical school instead of during third year. So that very early point in medical school carries a lot of weight for the student's future. So what is the way forward here? I would argue that we need to eliminate grades in our core clerkships and find other ways of assessing students. Ways that we could do that would be more well-rounded, broad views of students' performance that would capture the range of contributions that they're making in the clinical setting, with more use of narrative, more use of the student's own efforts at reflection and learning planning, that really paint a picture of how that student is progressing over time. You could say, well, wouldn't that be difficult for the residency program director not to have a transcript? And yes, it would, but there would be ways around that. Perhaps those narratives would be useful to residency program directors if they were constructed in a more information-rich way. Perhaps grades from fourth-year rotations, from sub-internships in key departments could be used in place of core clerkship grading. We need to find ways working together that allow students the space to learn and improve in their core clerkships, to develop those habits of lifelong learning that will help them to become the team players, the learners, and the patient-centered physicians that we are aspiring to train in our programs. So with that, I will stop and thank you.
Is there a clarifying question or comment?
That's great, Karen, thanks. At OHSU, we actually uncoupled the shelf exams from the clerkship grades, and we're putting in a framework eventually where we will strip out the grade, the tiered grading if you go pass fail. My question is centralized rubrics versus departmentally based rubrics. Do you have a comment about that? Because before we put our curriculum in, every clerkship had their own way of saying what counted and what weighted and all that kind of stuff. So comments about that part?
Yes. We have tried to standardize at our place because what we have learned is that small differences in departments or large difference in departments, even if they are very well intentioned, are surprisingly and enormously confusing to students. So they spend so much time trying to understand those differences that I think it takes away from their learning. We have heard from some departments that reasonable people would agree that the same form might not work in its entirety in our anesthesia core clerkship that would work in our psychiatry core clerkship. So we've tried to find ways of making the differences intentional and based on something. I think it's harder for the students when one department just feels like the clerkship exam should be worth 10% versus 15% of the grade. That seems to me to interfere with learning.
Continue discussion. Thank you.
Thank you.
Thanks very much. I'm grateful for the opportunity to talk with you today. I'm so incredibly stimulated by this meeting. One of the many reasons is the genuine conversation and conflict that we can face together, all with good spirit and good intention of improving medical education and the health of the populations that we serve. I've had the pleasure of working with one of our medical students, Ben Fresh, on a project out of his initiation because he wanted to say, how can we improve the match? Ben is somewhat of an expert on the match because he's the child of 2 physicians and a sibling of 3 more. He's watched this, and he knows that we can do better. And Ben's ending up in MedPeds at Vanderbilt, and I promise you, you'll enjoy having him. Most of you probably heard Dr. Marcia Rapley speak at the AAMC this fall. You know Dr. Rapley. She, in addition to being chair of the board of the American Association of Medical Colleges, she also is vice president for health sciences at VCU and their CEO. And in her keynote address in November, she said medical education is too expensive. Now, sure, that wasn't as sexy as the precision medicine and the artificial intelligence and so forth that we are all so excited about in planning for the future of medical education. But she's right. How we can cut cost in medical education is one of the most important questions we can ask. She said, without a new focus on the essentials of our mission, we may soon find ourselves out of reach, except for all but the most privileged few. She went on to say, I believe that the cost of what we do in education and in service, of course the cost of what we do in clinical care is a whole nother beast, but we only have 10 minutes. It's undermining our ability to improve the health of the nation, she said. Our cost is compromising our ability to prepare a diverse and inclusive workforce. This is something we believe is absolutely necessary to attaining a truly healthy nation, and our cost is impinging on our ability to sustain the world's leading research enterprise, which is essential to the discoveries that save lives. We need to improve the cost in medical education. The cost of attendance for medical students has risen tremendously within the last decade by 17%. Currently, the AAMC says the cost of attendance for a medical student is $249,000 for LCME accredited schools. And we know that the debt of those students is approaching $200,000 upon graduation. And we know that debt may or may not influence career choice. It certainly influences the practice locations and the practice types that our graduates pursue. We have to address this problem. And in addressing this problem, to me, decreasing the cost of the match is some very obvious low-hanging fruit. The current match is very costly for medical schools and medical students. Many published papers from a variety of disciplines illustrate that medical students charge on their credit card somewhere between $4,000 and $8,000 or $9,000 or $10,000 simply applying and traveling to interview. Maybe buying a suit or 2 suits, okay? And it's real easy to look at their credit card bills and come up with their cost, but what we're missing in that is the tremendous cost that we as medical educators are spending in this process. In pediatrics at UNC this year, to match our 23 incoming pediatric interns, we received over 1,500 applications. We chose to interview 300 of those students. In face-to-face faculty clinician time, we spent 8 weeks of faculty FTE in face-to-face interviewing, which is 800 clinic sessions if you're counting. And we spent over $15,000 providing them food, and who knows how much we spent on ridiculous plastic swag. So the match is really expensive. It's certainly costly in that direct cost, but what about the opportunity cost? I mean, UNC, we match out in less than 1/3 of those that we interviewed, and we are spending that opportunity to select that top 23 out of a large applicant pool because we care about getting to know them and so forth. But if we spend a third as many days, we could be spending the rest of our time improving our program. We're a strong program. Programs that have to interview all of their applicants or more of their applicants are in a similar boat, and in fact could be investing their resources more strongly. We all know that the match is incredibly anxiety-provoking at a time where we're working to improve wellness in our students. It's distracting attention from senior curricular experiences. Have you attended in October? This year, my fourth-year medical student on my service in October at least had the decency to say to me, Dr. Byerly, excuse me, but I'll be checking my phone after each patient room that we enter when we come out in family-centered rounds because I don't want to miss an interview invitation. This is a true story. I told Bill Cottrell I was going to tell it. I meet with the student body presidents once a month to talk about, things that we do for the student body. This year, they happen to both be going into pediatrics. And 3 hours before our meeting, they canceled a meeting with me in October because they said they had heard that Vanderbilt was going to be releasing their interview invitations that day, and they could not leave their laptops. So they didn't have 30 minutes to spend face-to-face with me. That's a true story. They're our student body presidents. The match is distracting their attention from their curricular and enrichment opportunities, and it is possibly perpetuating disparities as well. I'm sure I'm not the only one of you who has heard that, well, I'm not really interested in moving to the West Coast, but my college roommate is in grad school at Stanford. I'm just going to go out there and visit. This is a good excuse. Well, fine for Ben Frush with 4 siblings and 2 parents who are doctors, but for our medical students who are struggling to get the credit, to get a credit card, to make all those trips, they don't have the luxury to travel to Stanford for just to visit their college roommate. I think those opportunities create and enhance and continue disparities that we already are talking about in medical education. So here are some ideas for improvement. Now, I don't know that these, of course, are the best ideas, but heck, we gotta do something. So I think we at least could issue interview invitations on a firm date or a well-established series of dates like happens in the SOAP, so that our student body presidents aren't canceling their meetings and our family-centered rounds are not constantly interrupted by checking your phone to make sure you're not missing an opportunity. I also think that if we had established dates for inviting people to interview, that programs could fill their interview slots appropriately. We would know we don't need 300 people to interview, and we might choose to invite 200, which means that 100 that we knew we probably weren't going to match in the first place could choose to interview at some other programs who would really love to have them. And that if we filled our interviews in a sequential sort of way, with us agreeing to cooperate with each other in a teamwork-oriented fashion, I think the diversity of our match would improve as well. More controversial, but I think more effective, would be to cap the number of interviews applicants are allowed to schedule. Now I know, in our capitalistic American culture, where every individual ought to have every opportunity, this is going to be a hard battle for me to win. But in this session over the noon to 2 hour, one of the amazing Brown medical students who was sitting with us said that as he was applying to neurosurgery, he applied to 65 programs. Now, in the match, we know that 48% of students end up matching at their first choice. Now, the first choice, of course, is only a place that they've interviewed. So where you get to interview really is the magic door that you get sent through. But if he would have had a limited number of applications to consider, recognizing the controversy, then the 64 other places that spent some time with his application could have focused instead on students who really wanted to be at their institution for training. Similarly, we could cap the number of interview slots allowed to be extended. Maybe you can interview 10 times or 15 times the number of applicants for the slots that you'll fill. But certainly we could cut the cost down from programs that are matching 2 or 3 applicants and interviewing hundreds of fourth-year medical students flying across the country to do so. To decrease the anxiety and to decrease the cost that I fear will soon be escalating, we could stop that business of second looks. Because second looks used to be a great idea when people were really deciding which program between 2 or 3 they might want to attend. But now, when second looks are used to show that, yes, I'm really interested in your program, it's escalating the arms race. We don't need to go there. Finally, this group has to engage in this question. We are the they. Many of us are, you know that argument, we are the they that have this problem. It is not their problem, it's our problem. It is all of our problems. I have drunk the Kool-Aid that this consortium is serving. I believe that health system science really matters. I believe that in these things that you wrote in your book, Jeff, that we must be leaders as physicians, that we must care about economics in addition to medical knowledge and patient care. I believe we must add value through what we do in the educational process, and I am not sure the match, the way it is now, is adding value. I believe that we can improve the quality of systems and processes. We tell our students that they can improve the healthcare system. Let me tell you, the match is complex, the match is important, but the match is not near as complex or important as our healthcare system. And we are empowering our students to believe that they can do it. I would submit we can do it too. I believe in teamwork, that we can work with residency program directors to make this change. I believe that we should use the numbers we know. We know from the NRMP that if you interview at more than 13 spots, you don't change your opportunity to match at all. Every interview after 13 is a waste. We know, and we're not using that data. Our goals are to eliminate disparities in health. We have concerns not just for the individual patient in front of us or the individual student. We have concerns for the population of students and the impact for what we do on our population of students to the rest of them. And we are professional. We want to govern our own profession. That means we have to rein in the system of our profession and keep tabs on it. So I think we owe it to our students, our patients, and ourselves to address this wicked problem and improve our match system. Thanks.
Thank you. We have time for a clarifying question or comment. That was it. Okay. Go. Okay. And you will hear more from them in just a minute. Okay. For our last presenter, Richard Van Eck.
Thank you. My name is Rick Van Eck, and I am a medical educator. I came from the field of education and was hired to help medical educators teach better. And I'm going to be talking to you about that today. I don't have to tell you how high the stakes are for medical education. It's literally a life or death situation, the extent to which we train our students for the future. So it hardly seems like this is the time for fun and games, but I'm going to spend the next 10 minutes talking to you about just that, or at least half of that, and how video games may help us improve healthcare education. In short, we need our students to be able to solve a wide range of problems, students who see failure as an opportunity to try something else, who can set short and long-term personal and professional goals, who are aware of their strengths and their weaknesses, who are compassionate and empathetic, all while integrating technologies that have not yet been invented, working with people and cultures with whom they are unfamiliar, and designing a healthcare system we cannot yet imagine. Easy, right? Seriously, how do we train for something that we ourselves can't really define? I suggest that what's required is a fundamental shift in our conceptualization of what a curriculum is, and that video games can help us understand how to design that new curriculum. Now, there's two main points that I'm going to make during this talk. Games themselves can be teaching tools, as with serious games or games for health, for those of you that are familiar with them. And games are also a model for teaching the very same outcomes that I just listed on the last slide. And that includes things like resiliency, problem solving, empathy, collaboration. So let's start by talking about what the evidence says about games and learning. There was a study done, for example, in which 15-year-old adolescent girls played the game Tetris for 3 months. And functional MRI showed a change in cortical thickness and in brain function. Other studies, a series of functional MRI studies actually, have shown that video games induce activation of reward and motivation-related neural activity, that there are physiological changes that go along with what we expect the outcomes of video game play to be. In fact, video game play is the exact neurological opposite of depression. And there's, as I said, dozens of fMRI studies that back that up. And some of you may have heard that the amount of action video game play is actually a better predictor of laparoscopic surgery skill than years of experience or years of training. It trumps both of those. So games clearly make physiological and cognitive improvements, but what role do they play in teaching and learning itself? Well, to understand this, we have to make a distinction between games designed to entertain, or commercial games, and games that are designed to teach, which are sometimes called serious games. And one subset of serious games are games for health. We'll take a look at those first. But later, I will argue that it may be commercial games that hold the most important lessons for healthcare education. So what does game-based learning look like? Well, it looks like games like this. This is a game called Remission, which was used in pediatric oncology. And in this game, the player enters the body and has to deliver chemotherapy loads to the tumors and has to deliver drugs to protect the white blood cells, to protect against infection. And what they found is that it improved chemotherapy adherence in pediatric oncology patients, it increased their self-efficacy, and it increased their knowledge of cancer. It also looks like this game, Night Shift, created at the University of Pittsburgh. This improved immediate and delayed emergency room physician classification of severe trauma through this gameplay immediately and 6 months later. It looks like the game Septris, developed at Stanford, which improves classification and management of sepsis. And those of you that were at Change Med Ed in 2016 heard from Dr. Rahman at the Keck School about 3 other games, Prognosis, Medical School, Microbe Invader. There's a series of these. But there's other kinds of serious games for health, too. Here's an application that uses virtual reality. It's called Snow World, and it was shown to reduce pain in burn patients during wound care. And the application of this game plus medication was more effective than the medication itself alone. It also looks like this game called Fat World, which places you as a player in a low-resource urban setting with a budget equivalent to public assistance and access to the same food options that exist in those settings. And what you find through playing this game is that no matter what you make as a personal choice and what your intentions are, you are more likely to end up obese, diabetic, and with high blood pressure because you just don't have access to the same things. It's a very different experience than telling people about social determinants of health to put them in those agency experiences, especially if they've never seen that themselves. It also looks like this game application called Super Better. If you haven't seen Jane McGonigal's TED Talks, I highly recommend them. She had a severe brain injury, and as a result of that, she experienced suicidal ideation, extreme headaches, all kinds of vision and mental fog problems. She decided to turn her life into a game which she called Jane the Concussion Slayer. And she enlisted her whole family to participate in this. And so they collectively battled the bad guys, which were things like bright lights and crowded rooms and so forth. And she gave herself power-ups by finding things like spending time with her dog, taking a walk around the block. And the result of all of this ended up being the book that she wrote, Reality is Broken, in which she found that this experience not only helped her get through what she was experiencing, but actually made her a better person at the end. And it's a lot of science behind that to back it up with post-traumatic growth that's being talked about now. So does that mean we need to make students play these kinds of video games? Well, maybe. In fact, probably. But that's not the only way that games can help us. I say that understanding how games promote things like problem solving, motivation, and resiliency will help us understand how to do the same thing with our medical curriculum. And that might be the most important benefit of games. For example, games teach things like problem solving. This is a movie of a game called Gabriel Knight, in which you play somebody who's inherited their uncle's castle, and the village asks you to help them with a problem with werewolves. And in doing so, you have to go around in different places. You have to collect fur samples from the zoo and from the place where the attacks have happened. You have to do plaster casts of paw prints. You have to run DNA analyses, et cetera, et cetera. And what I'm showing you here is about 5% of the problem solving that happens in this and just about every other game. In fact, you can think of games as a series of problem-solving chains that increase in complexity over time. And actually, that's problem-solving is one of the key outcomes of playing games because you spend so much time doing it. If you look at that center of that diagram, that's where we spend most of our time during problem-solving, in formulating hypotheses, taking some action, more often than not failing, and then having to go back through that cycle. That's actually what makes a game engaging. And what you learn from that process is not just to be a better problem solver, but you learn that errors are a requisite to solving problems, that you will fail more often than you succeed. And that's what builds resiliency. So what do we do, though, about problems that are too hard, where you can never get out of that cycle in the center? Well, games teach you that you need the help of others for some problems. So I talked about those problem-solving chains, which increase in complexity. At the end of each one of those chains is what's called a boss fight. And that boss fight is something that, more often than not, you cannot solve yourself. And so this is a screenshot of a game called Dark Souls 3, which is the meanest game ever played. It kills you without apology. And in this case, you've invited 2 other people to help you take down the boss. And later on in the game, you'll probably go and help them or some other people take down a boss when they have to fight it. Now, I'm going to use this game to give you some additional examples. So games teach you about identity. They teach you that you have different kinds of characters, and each one of those has different skills. You have to choose one of those. They also teach you that no matter what character you've chosen, you also have to invest in skill sets, and you have to do so mindfully, because where you devote your points that you earn during the game determines how powerful you'll be and in what ways later. And these are the same kinds of skill sets that we need for teaching students about professional identity. Games do this naturally. Games also teach you that regardless of who you are or what skills you've chosen to invest in, you may adopt very different strategies for solving the same kinds of problems. These 4 images represent my brothers and I when we play this game. On the far left is my brother, Henry, who chooses to go through the game with the least amount of help possible so that he has to be very strategic and very mindful about what he's doing. My brother Tom, next to him, loads himself up with all the armor and jumps right into the fray. That's his approach. My brother John casts spells on himself so that he looks like an inanimate object, and he backstabs the enemies when they walk by him unsuspectingly. I'm the guy on the right. I prefer to stay well away from all the danger and hurl destruction from afar. I think it's a much safer approach. And games can even teach us about empathy, morality, and ethics, things that you can't really learn if you don't experience them. This is a picture from a game called Fallout, and you come across a village, and in that village is a tree creature named Bob. And he has mutated from human to a tree through radiation and chemicals and so forth. And it's extremely painful physically and spiritually for him. And he asks you to end his suffering. But he's also the cultural and religious touchstone of the entire village. And if you kill him, it's very likely that village doesn't survive. So there's no right answer to this. And games are replayable, so you get to see what the consequences are of one decision versus another. Neither of them are any good. So these are the principles I would argue we need to apply in healthcare. If we want to build flexible problem solvers, we need a curriculum that provides more practice solving a wider variety of problems. If we want students to be able to solve emergent problems, they'll need to practice identifying problems on their own, not just solving the ones that we create. If we want resiliency, we have to design our curriculum for failure, not just success. We don't do that enough, I think. And if we want students to be self-aware, we need a curriculum that ensures that the problems they encounter will require and reward the investments that they make in their personal skills. And finally, if we want them to be moral, empathetic, compassionate, and ethical, then we need a curriculum that forces them to confront problems with no good solution. And that's where video games may be able to help, both as teaching tools, as with Games for Health, and as models of how we can build the curriculum of tomorrow. I have a set of selected references, which I'll share with anybody who cares to email me. And this is my contact information. Thank you.
question or comment?
Hi, it's Rochester from MSC I think your last point is very, very important. That concept that video games may be able to help students to learn empathy and compassion. Another product, another game, I don't know if you're aware of, is called That Dragon Cancer. And it was written by two parents who were losing their child.
Powerful.
And that one has been, a number of students at our medical school have mentioned playing that and feeling that that gave them a much better understanding of the emotional loss and the helplessness that parents go through with dealing with a child with cancer. So I absolutely appreciate your sentiment regarding that.
Yeah, it's a very, very powerful game, and it's available out there, and I do encourage you to look at it. It's not one to take on lightly. It will affect you. Yeah, it's a big one.
Okay, could we ask our contestants, no, it's our scholars, to come up and sit at the table. If you want to stretch your arms for a second as we get ready. And if you have the lavalier mic, if I could ask Mike Mello, Mike, could you come and grab the lavalier, and we're going to take some questions.
Take that off the screen.
Yeah, we can take it off the screen. Questions. So, this is your opportunity to ask questions that pull together these talks. It can be something that you talked about in the groups or during the morning. This is the time for integration. So they're at your service for the next 24 minutes. And Mike will bring over some. Bring over the mic.
I have a question regarding clerkship grading, because that's certainly been an object or a subject around which there's been a lot of passion at our medical school. And I think there's a lot to be said for no grading versus pass-fail versus a tiered grading system. But if one goes for no clerkship grading, do you worry about introducing mediocrity and not striving for excellence? And how do you motivate students, or do you rely on their intrinsic sense of motivation to be the very best that they can?
That's a great question. So if we eliminated core clerkship grading, would students be motivated in the core clerkships? Ideally, I think from the beginning of medical school, you're encouraging intrinsic sources of motivation, and similarly, the way that they attribute their successes and failures to be intrinsically rather than extrinsically oriented and within their control rather than not. It's certainly something to think about, for example, in relation to timing of the STEP exam. If they have a STEP exam right after the core clerkship, how might that create an incentive that you don't want to be there to pull them away from the clerkships? Fundamentally, I believe that students come in highly motivated to learn in the core clerkships, and this is really the reason that they came to medical school, and they know that they need to do well in those core learning experiences to succeed in their sub-internships and their residency. So if, for example, you were to have pass-fail grading in the core clerkships that would ensure that everyone had demonstrated they met the minimal competence, there could still be some kind of information out of that might be useful as assessment information to be reported summatively, or perhaps not. But the student still needs to learn what they need to learn to succeed in their sub-internships. So I think that with the proper culture, learning environment, and coaching, you could accomplish those things, because the material is fundamentally motivating, because that's why people came to medical school. I think we've created a lot of maladaptive motivations around that in our current system.
There's a comment over here first, and
Is it related to that?
no. Can I just say who you are, too?
So I'm Allison Whalen at the AAMC. So I have a brief follow-up to that, and then I wanted to talk to what Julie had said. That same question used to come up for the pre-clerkship grading, when those were all graded, and it was, students will stop studying, et cetera, et cetera. Many schools have changed to that, and there's a fair amount of literature out there that it did not change performance, did not change students' motivation, did not change performance on Step 1 exam, et cetera. I think there's a whole other potential set of things when we think about Step 1 related to changing the clerkships. But it didn't show up in the preclinical years, so why would you expect it to show up in the clerkship years in terms of motivation?
And
So-
those changes improved students' well-being and reduced stress.
At least in the
the
short run,
first
yes.
part of the curriculum with the elimination of grades.
The data's been showing that as well. So, Julia, I just wanted to comment on some of the work that the AMC has been doing related to the broad topic that you talked about. Incredibly important. And the emphasis that we've been working on is not trying to change policy about how many you can apply to, but really share data so that students are applying more strategically, people can advise them more strategically, and programs can potentially select more strategically. And the two big things is we've been sharing data about really the diminishing returns on interviews. So it's by specialty, by third of step one exam, and then looking at the curves of how many applications do you begin to see a flattening of the curve. It's all published on the website. It's not the be-all, end-all, but it is the beginning of more sharing of transparent information is one piece of what is out there. And then we're beginning to look at other really doing human-centered design and saying what else will help folks. And students are saying we want more information about all the programs. So we're trying to find, using data that we have, can we get more information more consistently there so more students can see that, and potentially pairing with other organizations to share that as well. So I think sharing data is certainly a first point. So I would encourage you to look at the transition to residency stuff on the AAMC website, which is just the beginning of looking at applying more strategically.
That information is incredibly helpful, and I'm very glad it's available. Not only do students appreciate it being shared, though, but we as their advisors have to trust that information and give them the advice that matches that content. And then also we have to be more forthcoming with that content earlier on so that the students know what to expect, and it's not December when they learn that.
Julie, also to follow up in the area, one way that we've looked at trying to help assist the students is to kind of further build our connection with alumni and basically look at it as if they're going to various places, can we identify alumni who are either in particular programs or would be amenable to, let's say, hosting them. I mean, I saw outside a nice chart here at the school about the number of hosts for the students. I think similarly, again, even whether or not they stay at an alumnus' house, knowing the best hotel or the proprietor, let's say, that could make them feel at home, those little things certainly help make a difference, help the individual focus, if you will, their overall well-being as well, going into the stressful process of interviews. So that's one way, in essence, we've been trying to make a difference, however big or small, but at least in that way, not only you're looking at let's say, the problem at hand, but you're also at building a lifelong, potentially, connection as well.
I had a question for Julie. I just wanted to know your comments and thoughts on the trend that medical students who are going into very competitive specialties will often use other specialties, like for example, like family medicine as a backup, and also your thoughts on like the NRMP not letting programs ask medical students if they're applying to different specialties.
Right. So my thoughts are just one person's opinion. I don't sit in any official capacity related to either of those, but my own opinions are that one of the things a program director is looking for is the genuine journey that an applicant can support. And I don't think that students should be limited in how many places that they could apply, but I would argue that students should be limited in how many places they should interview, and it should be a generous limit. But if you set if we know that on the match list in ENT, and I don't know that off the top of my head, I know the match list overall, if you rank 13 places, you're very likely to match successfully. Yeah, so it is specialty specific, of course, but let's suppose that the ENT number is 25. If we chose to allow students to interview at no more than 30 places, or 35 or 50, it doesn't matter, but a number set, then that student would have to juggle how many of their 50 interview spots might be at a backup discipline. but at least that they would have some sort of idea that if they were offered 35 interviews in ENT and 25 was last year's magic number, they're probably going to match an ENT, which would free up family medicine interview spots for someone who has a genuine journey, a genuine interest in that discipline.
Question over there, and then in the back.
I'm curious, Richard, if you could think about ways that you all might. Oh, thank you. Ways that you all might be able to put your two slants on the use of videos into medical education, especially in terms of the adaptive learner and those kind of things.
So I'll take the first crack at that. Actually, when we were exchanging the slides, my first thought was, I think we're going to be talking a lot about the same thing, Sentil and I. And it's a gamut. So I think sometimes we think about a technology and an approach as if it's a panacea, and if you're going to use it, you're going to use it to its fullest extent and everywhere. It's the same thing that happens with active learning. We tell people about active learning, they immediately think that they have to flip their entire classroom, and there's different levels of it, right? Games are a way of employing situated learning, the same kinds of rationale and pedagogy behind clinical experiences. We're providing real-world experiences. Now, it's weird to say that when it's a simulated experience, and you could argue about whether it is identical, which it's not, but it's very effective. And when you're bringing those kinds of things, so those videos could be standalone, they could be integrated into a game, they could be part of a simulation. We're talking about recording our simulations at UND and making branching scenarios out of them so that people could make decisions about them. So the full wide range of those kinds of things are what we need, and we need to bring it to bear intelligently where it's a problem that the technology can really solve, and not to try to make square pegs fit in round holes.
And I agree. I think it's the framework of using this across the continuum. Actually, when we wrote the proposal for the Stimler grant with this, we wrote that as a tool that can be tested across the continuum, addressing a question of master adaptive learner. You could cut the video at any point you want and ask the resident what next, what's the best next step. So what I shared today was two very easily detectable ones, and to show that it's reliable, you can produce those videos. That's what I showed. So, and you can ask the same question at the preclinical level, or at a clerkship level, or a GME level. So it is that framework applies to the master adaptive learner. Yes.
First of all, I thought all the talks were terrific. I'm in the back here. My specific question is for Julie. And Julie, wondering, of the many great suggestions you gave, how many of them do you think are generalizable to international medical grads? In other words, should the match solutions be the same or perhaps different for those two groups of U.S. medical grads and other non-U.S. seniors, if you will, given that there are maybe different drivers in the match?
Sure. And I think that we need to be looking at the data, and I don't know the data about that well enough to simply make a proposal. However, the overarching argument that I want to make is that we need to treat ourselves as a community of educators, just like we're asking our learners to act as a community of physicians and own responsibility for the systems in which we work. And so to get at that, I'd be interested in looking at the data more specifically about what happens in successful matches of international medical graduates, and in also successfully supporting programs that fill with international medical graduates. I do think that we could end up with different mechanisms there in the match. You gave me more to think about this morning about what Step 1 scores mean to international medical graduates, different than what I've previously appreciated. However, I think if we were able to sort of rein in the match, perhaps by decreasing the amount of wasted program director interactions with potential applicants, then the international medical graduates would also reap the benefits of a more efficient and leaner system.
Thank you. I thought all of the talks were really interesting and lots of food for thought. Julie, I'm going to continue on with the match match conversation, which I appreciate your teeing up for us. Just also in relation to your other two colleagues, what I didn't hear from you is any thought about, can technology help us reduce the costs? I mean, we do a lot of senior leadership searches, and increasingly all of our first round interviews for our senior leadership searches are Zoom-based group interviews with a committee, and we're willing to sort of use that interview to make a preliminary decision about who goes on to another either in-person interview or a more detailed Zoom-based interview. And so I'm wondering what your thoughts are about the pros and cons of how technology might help us decrease the costs, maybe focus our energies for in-person interviews, and in a different way than the standardized video interview, because the problem with the standardized video interview is it's one shot. You only get one time to actually improve your interview skills, whereas if you had a series of Zoom-based interviews, that you might be able to improve along the way. So I'm curious to think about what's the opportunity for us evaluating future residents for our programs, but also whether technology, and maybe the other people can pick up on this, might actually be a way that the students could learn about the culture and climate of the programs that they're looking at.
Certainly, I think that you're right, that we have to use technology to improve cost effectiveness in all of what we do, and we can do it educationally. Yes, I was going to compliment the standardized video interview until I heard David Henderson's comment this morning and thought that I shouldn't. No, I'm teasing. But what I was excited about the work in emergency medicine, they did the standardized letter of recommendation first and then a standardized video interview. At least they're trying something. And I think that that's a positive, recognizing the concerns about bias or rehearsal that might have been the case in the formatted interviews the way that they were done this past year. I do think that it used to be important to travel across the country and tour a different hospital setting to see if you could envision yourself living there. I'm not sure if that's as important anymore, given the ways that we can get a feel for a place through the use of video and other technologies. Certainly, and sequencing our interactions could be done more so in the match. The match was put in place because of the chaos of a discoordinated or an uncoordinated system. The SOAP process, by my impression, actually works quite well because it's very well coordinated and sequenced. And we've been hung up on one opening date for ARIS, one release date for the MSPE, and one single match date. But it's possible that we could be creative about ways that we sequence those pieces and have more of a step-down approach toward achieving a single match as well.
I think using videos can be a huge value because, as I mentioned, Anne Kring's work on recognizing facial expressions to assess read in between lines, so to speak. And so that can be used as a valuable tool. Only thing I would add is to make sure that if we are suggesting that approach, to couple that with training of the people who are assessing those videos and video calls and giving them proper training and bias and et cetera.
Questions for Richard. The development of a serious game nowadays, electronic arts and developing a game is a multi-million-dollar movie type of investment, and it needs to play to a large base. A lot of people need to use that thing and contribute their $100 to the development of that game. How do we, as a medical education community, get to the levels of authenticity that you've suggested in your presentation, and how can the AMA, the AAMC, the DOD, whoever it is, help us in terms of getting to critical mass in that sense?
So that's a great question, and it has a multi-part answer, so bear with me. The first part of the answer is that we're not competing with electronic arts. We're competing with the textbook and the lecture. So to a large extent, the bar is fairly low in terms of realism and authenticity. But your point is...
The idea that the medical education researchers are using crippled versions of games affect or go better than the existing, does us a disservice in that sense?
You know, that's a fair point. And I guess it's going to depend on the outcomes that we're trying to achieve. And if we can't achieve those outcomes with existing practices, then it might be worth investing large amounts of money to make sure that we can build something that does do that. But it has to be a large enough problem to justify the expense. I've been involved with the development of 4 or 5 serious games that have had a budget of $225,000. Now, they're very small games, and they don't have tremendous fidelity in terms of realism. But the good news is that when we're teaching a lot of the research on simulations and video, because way back when we thought the holy grail was 30 frames per second full screen video, and it turned out that people actually learned better from stick drawings, figure drawings, than video in many cases, because there's too much complexity going on and novices don't know where to partition their attention and so forth. So we can achieve some outcomes with very low fidelity. But I would also say that actually the more important aspect is that we don't actually have to build games to use games for the curriculum. I think that's the bigger lesson. And if we understand how games promote problem solving and how they create different kinds of problems and how they model the kind of motivational things where you invest in certain skill sets and as a result that leads someplace, if we take those same things and move them into our curriculum, and I didn't talk about gamification, but that's one of the main ways to do that. So for example, if rather than one of the challenges with portfolios during the match and the evaluation is that who's got time to read all those, that's why we end up going to the step 1 scores, right? So if you're trying to figure out what students are really good at, if you had a portfolio of badges that had a series of levels that went to them, you could see where a student had chosen to invest their time, because there will be more things that they could demonstrate achievement in than they can do in 4 years. And so they will have chosen to emphasize certain things that they're really good at, and those become markers of expertise if they're tied to real competencies. So things like that, adopting those principles. We've got one of my colleagues here, Dr. Johnson, is working on interprofessional competency checklists, where students would have to complete a certain number of activities per year, and they have to self-identify some of those activities, and then demonstrate and assess their own competence in that, and that becomes part of the way that we assess interprofessionalism. So there's a range of skill sets and abilities and things that are done within games, and I think if we understand how that happens, there's a lot of that we can employ, even if we don't do anything with games in our curriculum.
Last 2 comments.
Julian Senthil started me thinking about the whole issue of health system science and stewardship, and then I started hearing the rest of it, and my question, and maybe it's a suggestion for Susan, is aren't all 4 of you really talking about the beginning of educational system science? And what would the quote textbook look like, or the domains look like, for the systems aspects of whether it's pedagogy, cognitive load, the effect of wellness, the whole mirage of is it really objective or not, gamification, all these different things. I think all of you are touching upon what do we know now, and what do we need to know in the future around the systems issue of educational delivery, especially with this idea of cost. And so I think we're onto something here, and it's something I think that we could chew on further. And I'm going to make a suggestion for an interest group.
Sign me up.
Thank you so much for your commentary about saving cost in healthcare education. That's a big concern of mine as well. And specifically my question, and I guess getting back to the idea of video interviews, I look at the cost of healthcare, and you correctly stated it's around $250,000 students are paying. And if we look at the 5,000 or so that are involved in the application process for residency, I worry about starting with that small, tiny piece of the pie. And the reason why is the idea of the interview, although I would laud the idea of perhaps limiting the number of interviews they take, the idea of the interview has a dichotomous purpose. It's not only for us to evaluate them, but it's for them to evaluate us. And I think if we look to our own experiences of applying to residency programs, it wasn't the interview that helped make us make that decision. It was the experience of walking around and specifically meeting all the current residents. I would worry about a video interview having a negative impact on students' abilities to really evaluate a program.
Very good point.
So any final comments that you'd like to make? Something that you didn't get to say?
One thing I
Okay,
would-
well, the question, Senthil?
Yeah, I just wanted to make one small comment that when we designed these videos, what I didn't get to share was the cost it takes to create these videos. It's comparable to what the NBME spends to write one item, but then with the approach that we take of using one video to write multiple questions, it cuts down the cost to 1/6, 1/8, 1/10, or 1/20th, depending upon how you use. One additional thing that, last thing I'd make is, one comment we had from the NBME Stemler grant award was, how do you ensure that the students are not passing on information? The person with the red shirt is, ACE inhibitor-induced cough. The person with the red hat is something else. So we have a simple, our group debated a simple idea of making all the videos black and white, so.
Well, and I think if we come together in another 20 years, it's going to be interesting to see if you can pull together all of your ideas and synthesize them. If we can go beyond MCQs, beyond the illusion of objectivity, we can have high value, be cost conscious, and maybe fun. Maybe we'll have avatars that will come and they'll interview, they'll assess, they'll choose residencies for the individual, and there'll be good choices. But until then, so first of all, a round of applause for our presenters. Who presented highly technological presentations, all on time, within 12 minutes, which was remarkable. So we'll be switching gears. From 3:30 to 5, we have educational posters that are all on I believe, on the first floor. Combination of those from Brown and from each of the constituent schools in the consortium. So we're thrilled to have them. Thanks to Emily Green for helping to get the afternoon together. So there'll be 3:30 to 5 on the first floor, and then each of you has a map, hopefully, that's at your place to get to the Rhode Island Museum, Rhode Island Art School of Design Museum, which should be about, 3-minute drive and maybe a 10-minute walk from here. It's a beautiful Rhode Island day outside, a wonderful day, so thank you all, and we will see you outside and at 6 o'clock.